the sake of seamless audiovisual, you are listening to a pre-recorded video. When pediatric anesthesia and implications and its Indian perspective especially is what we are going to look into right now. It's intriguing to note the fact that a while ago, a couple gave birth to twins and they had really a difficult time. It was in Raipur. And to remember this, they actually named their babies as COVID and Corona. I must say, India has a different perspective on everything. So, yes, we are in crisis, and yes, we are here to manage it. We are under pressure. So, when rocks go under pressure, they turn into diamonds. So, this is what we are now undergoing, I guess. And a lot of our practices are indeed going to change. So, let us see what best we can do in the given scenario. Having said that, let's understand the scenarios. Well, in December 2019, viral pneumonia cases of unknown etiology did surface up in China, only to understand that it was a totally different virus named COVID. We all know this. March 2020, WHO said that this is a pandemic, and it was in January 30th that our country reported the first COVID case. Coming to pediatrics as such, our infant fatality was the first 45 days old baby. This was the first fatality we had, and it surprised us as such because we thought that very small babies should go exempted. But the vertical transmission, yes, the infected mothers are giving births to uninfected babies. So that's also good news. How safe are Indian children from COVID-19? If that question has to be answered, it goes as follows. This data has been taken from this particular special article written in Indian Pediatrics. So they say that it is 1 to 5% of diagnosed COVID cases. And although they may be infected, the infection is rather asymptomatic, or it doesn't go to a very high severity. And secondly, we may not be diagnosing because we need a lot of population screening to diagnose the real percentage. But the fact remains that children are spared to quite some while. Now, so towards children and against the to and fro towards it, 90% mild to moderate infection, and then around 5.9% are the critical cases as such. Now, what we need to keep in mind is asymptomatic children are less likely to be tested, so we really wouldn't know and still might continue to transmit. That's something that the healthcare personnel, especially for children, must keep in mind. So I guess everybody who comes on table, we need to suspect them having COVID anyways. How does the transmission happen? From a positive adult, of course, and then it goes to a baby or a child. Now, why are the viruses so kind to kids? There's a reason behind. Because children have a healthier respiratory tract, milder exposure to pollution, most of them play at home. Cigarette smoking, obviously, contribution is nullified. And distribution, maturation, and functioning of viral receptors such as ACE is different in children. And these are the actual receptors on which the virus go and lodges themselves. Now, these are present in the respiratory tract. These are present in the gastrointestinal tract, and hence the symptoms. But since the distribution might be different, then children have milder infection is what is thought of. This is the Indian data. I'm sure by the time I am speaking to you, it must have changed. Coming to how does it really present in children is, first 3 to 14 days is maybe more of an incubation or symptomatic period where they could be all for playing, or they're going to schools, of course not now, but they are absolutely normal and they might just walk in for some other emergency such as a CLW or elective once they start. Later on, they might have symptoms, but the less graver ones such as fever, URTI, vomiting, diarrhea. Later on, they will go towards fever and LRIT, the lower respiratory tracts, and the X-rays will show something. The severity will later on prop in, and by this time, it's not that common by this time. So it is hypoxia, it is decrease in oxygen saturation, the respiratory rate is going to be less increased now, and then the final worst, which is ARDS and multi-organ failure. So this is how the disease will go ahead in children. As anesthesiologists, when are we going to come in contact with them? Especially, of course, during operations, or if we are on the PIC or casualty fronts. So mostly it is always in the operation theaters that we are going to work with. And it is needless to say that today, I think every baby or child who comes on the table has to be kept in mind to be suspected positive or positive cases. What is the balance that we really need to strike at? We are looking at a highly communicable disease, but we need to offer care. So we need to offer care with total self-protection. That's the balance what we are looking at. Another balance, impending one, is what is ideal and what is more practical. So I'm not too sure what protocols would really emerge as final ones, but all I would say that there are protocols for today, and for today we need to absolutely abide by them. This is like protect yourself first. That's how even the aviation industry says, because unless you protect yourself first, you probably will not be a good helper. You won't be in a situation to help somebody else better. Having said this, my good friend has also chipped in what he thought, and after writing the long list, he says that this is a very dynamic stuff. What we speak today, what we read today may just not hold true for tomorrow. Having said this, the operation theater, the pre-op, I shall hand it over to Dr. Ankit, and I shall come back and take the rest, such as one or two specific diseases, and then the focus in children. Over to you, Ankit. Thank you.